Happy Teach Me Tuesday. My name is Lisa Houston, and I am a clinical nurse educator in the NICU, bringing you little bits of education every Tuesday. We have been breaking down necrotizing enterocolitis during the month of May, as it is NEC Awareness Month in May. And we have spent 4 weeks. This is week 4 of talking about different parts of risk factors and treatment and prevention for NEC. We talked about the placenta and the in utero things that go on that we as bedside NICU nurses can't really control. Then we talked about resuscitation and vital signs and how can we help support babies through that. Last week, we kind of put it together with some of the preventative methods in the gut biome and really talked about kangaroo care because it is also Kangaroo Care Awareness Month. And so this week, we're really just going to kind of dive into what is NEC and how do we treat it and kind of how do we classify it. So kind of the meat and potatoes, the pathology of all of this. So we're going to look at some x-rays and we're really going to just kind of dive into it. This might be a slightly longer video than 15 minutes, so stick with me. So let's talk about NEC. NEC, as we all know, is a severe gastrointestinal disease that affects babies primarily born premature in the NICU. You can get NEC if you're not premature. It is less likely, but it is more tied to those ischemic events that happen or a baby that is severely IUGR. Again, if we flash back to the first week when we talked about the placenta and the in utero things, that's kind of where this other NEC cases come from. But there's this inflammation of the bowel wall from bacteria invading it. And really, when we think of it, it's an injury to the inside lining of the intestines that allows bacteria to come in, and then it goes into the bloodstream. So if we can talk about the risk factors and the diagnosis and the management, we will be able to also talk about prevention. We really want to be able to put all those parts together so that we can improve the outcomes for those babies that have NEC. So here's our big scary belly, the belly we've all seen, unfortunately. So NEC is characterized by that intestinal inflammation, and there are so many things going on. We talked last week about the immature gut and the dysbiosis that can happen from bad bacteria outweighing the good bacteria. We really talked about with both the placenta and the in utero stuff and the resuscitation and the vital signs is when there is impaired blood flow from hypoxia or reduced perfusion that the baby is at higher risk of NEC. And that is because the body is going to shunt the blood to the vital organs. So then we get the bacterial colonization and all of that kind of comes together. And we haven't during this month talked about probiotics. I haven't really brought it up here because most units have stopped using them since the FDA kind of recommended that we shouldn't use them. And so previously we talked about why we use probiotics is to have this good bacteria outweigh the bad bacteria, but now we're going to have to do it with other ways, such as what we talked about last week with kangaroo care and getting that flora from mom or dad, really getting onto their skin. We talk about it with oral care, oral immune therapy, kind of getting into the baby. We talk about it with healthy practices with not overusing our antibiotics, etc. And we also have our feeding practices. Interestingly, which I will mention again, they have found that the number one thing that units do to keep their rates of NEC low is have a feeding protocol and have a feeding practice that includes the use of breast milk or donor milk for babies born under 1,500 grams for a period of time. Every unit kind of differs. And to have a standard incremental plan. And to try to kind of keep those babies away from formula if they are born too early. And so that is something that we can do. But if we give those babies formula too early, we can actually increase their risk of NEC. So let's talk about the signs and symptoms. What are we as a bedside nurse looking at? So we have an x-ray in here of kind of this baby with these big loops going on, this little isolated loops, probably some little pneumatosis going on down there. If you watched our chest tube video, you know that I am not a radiologist. So, it's not my jam to diagnose x-rays. But in general, we can talk about what we as bedside nurses are used to seeing. So if you have a baby exhibiting things such as redness and discoloration of their abdomen, that tautness, when you kind of look at it like on that previous screen, you're like, oh no. Pain, tenderness, visible bowel loops, absent bowel tones, all of that. We really get into a place where we are concerned about the baby. For their vital signs, we're looking for hypotension, bradycardia, apnea, temperature instability. The tachycardia is often coming from pain. These babies frequently are in pain. It's like this terrible stomach ache that's happening. So we really need to be watching for those changes in their vital signs. I always like to talk about like output, like what are our babies doing? What are they giving to us? And that usually comes in one of two areas. So green emesis and vomiting, which I like to differentiate between a little spitty baby and a baby who is like vomiting. We all know what we do when we don't feel good or when we need to get something out of us. We are vomiting. So you also can have bloody stool, or the baby could completely stop stooling if there is a complete dead bowel and nothing can get through. So where it just kind of tight, loops off and the bowel is stuck on one side. So that is a situation that can happen as well. Otherwise, we may also see decreased urine output, poor perfusion, metabolic acidosis, and then this kind of change in the state, either profound lethargy or crying, which is going on both ways. Like, I don't feel good, my body's fighting something, I'm lethargic, or I'm crying because I really don't feel good and my stomach hurts. So that change for them. This is where our parents come in and they can really tell us this changes that they are noticing in their baby. Like, hey, usually my baby like kind of fusses when we change the diaper and take the temperature, and I'm noticing that they're not doing that today. That's really unusual for them. That would get my ears up and be like, okay, what else am I looking for and getting my assessment in? So how do we diagnose NEC? Well, we're looking at those clinical signs, so that abdominal distension, feeding intolerance, bloody stool. We get some labs. Maybe we're going to see a left shift on our CBC. We might see some metabolic-dosis, especially metabolic acidosis that's kind of out of nowhere. Thrombocytopenia. We're looking, maybe you check a CRP on your units, remembering how non-specific and non-localizing CRPs are. All there is a marker of inflammation, so could mean anything. And then our x-rays are definitive diagnosis along, obviously, if we are opening up and having surgery. But abdominal x-rays showing pneumatosis tells us that the baby has NEC. If you don't have that pneumatosis, we typically are using that stage of where we say like the baby has a big belly, or they have feeding intolerance, or they have swelly belly. And we're kind of going from there, and now we're saying that they have NEC. So Bell's staging is the most common that you're going to see, where it's broken down into 3 stages. And really kind of stage 1 is just that baby that probably has that big belly syndrome. Like they're just uncomfortable, they look really big, maybe they're on non-invasive ventilation, and they might have some distension, maybe some more spitting, but they don't have pneumatosis on their x-ray. When we get into stage 2, which is like really when you're going to see NEC and put it in your diagnosis codes, is when you see pneumatosis on the x-ray. So stage 2 here, they're talking about how it's focal, like it's in one area, we have moderate distension, etc. Stage 2B is when it's widespread pneumatosis, you might have some portal venous gas. And then stage 3 is when the baby has 3A is when they have moderate severe bowel loops, and 3B is when there's perforation and they have free air on their x-ray. So let's take that into these x-rays. So again, I'm not a radiologist, definitely don't want to be one. And so let's look at these x-rays through the eyes of kind of what would I be seeing to be like, oof, this looks a little rough around here. So in the top 2 x-rays, we are seeing areas of pneumatosis where it's kind of along that bowel wall. I like to think of it, some people would describe it as soap bubbles. I think of it as kind of like train tracks, like these areas of loopiness are very outlined. Over in the top left here, you can see the top x-ray, kind of just this whole area where there's these little bubbles showing up in and out. And then you're seeing it on the opposite side on this x-ray over here. At the bottom, we have the signs of free air. So sometimes this is called the football sign because the air in the peritoneum is making a complete circle around the baby. So the bottom one on your right is probably the most one that you can really see that. On the left, you're seeing it here just a little bit over the liver. And so this is not where we're supposed to be seeing any air. Again, it does look giant here as well, but this is where I most likely see it. But down here on this one, you really see that outline of the air where it should not be. Additionally, you're seeing areas of pneumatosis, that soap bubbling, the little spaces in between what would look like railroad tracks. So now what do you do? I think it's really important to know that not every baby that has NEC is going to need surgery. Surgical intervention is only for those babies that have perforation or necrosis where they can see that there is no air coming through. When there's no air in the rectum, that tells them like something has probably completely died and caused an ileus. So typically we're going to do supportive care. So we're going to do gastric decompression with your Replogal or your sump pump or whatever you call it on your units. We're going to be giving them antibiotics. They're going to be NPO. That is the majority of NEC cases. So that's going to be your Bell staging 2, maybe 3A as well. Lots of antibiotics, lots of parenteral nutrition to keep them growing, lots of supportive care. Maybe they're having blood pressure issues. We're going to be doing dopamine. Maybe they're in DIC. We're going to be getting some blood products going. Surgical interventions is for the babies that have a perforation. And not every baby that goes to surgery comes back with an ostomy. So it's very specific on kind of what the baby needs. I'm definitely not a surgeon. Definitely not. I didn't even work at a hospital that did surgeries for the first 13 years of my career. So this is something, if a baby had NEC and they had a perforation on the unit I used to work in, we would ship them to a different hospital to get surgery. So working in a hospital now where we do these surgeries, I have learned so much more about it, and it's been very eye-opening. I highly recommend if you're considering ever moving to kind of find a unit that's a little different than your first one. So with these, they may end up, some babies start with a drain. That was probably the craziest thing I saw. At first, when I was like, okay, there's like a drain in a baby. Like I just wasn't used to it. It was new to me. I had to learn about it. But this is when they kind of put a drain in and just kind of let the air get out and try to figure out where the hole is. But then those babies often go down to surgery to remove necrotic bowel, any sort of drainage, put an ostomy in, really clean out the gut. You'll see the surgeon kind of going through all of it and looking like, is there any areas that is necrotic or may become necrotic? Are there areas that are completely dead? How much will we need to remove? And of course, as we know, the more that they remove, the more at risk the baby is for short gut syndrome and or death, right? If we have to remove all of the bowel, or if they open it up and all of the bowel is dead, it's called NEC totalis, and babies aren't going to recover from that. So NEC totalis is the worst form. It will lead to death. The baby cannot recover from that and will probably have overwhelming sepsis. So we have these 3 kind of stages, right? Where first we're just getting a Replogal or a sump pump in, where we're doing gastric intermittent decompression, getting fluids out, get air out, etc. We're then starting with our antibiotics, our fluids, giving them electrolytes, whatever we might need to, and then some of our babies will need surgery. So all of these babies that have a diagnosis of NEC with pneumatosis on their x-ray will have antibiotics and gastric decompression, and then some of them will require surgery. That is kind of how I have had to do it. It's not, I think that there often is this idea that if a baby has NEC, they will need abdominal surgery, and that is not always true. If we could just prevent it and get rid of it. The NEC Society is one of my favorite pages. I will link that in my Instagram today if you want to go to my Instagram and kind of see some of our resources. But the NEC Society was founded by parents who really hadn't heard of this thing called NEC, and then their baby got it. And they are really pushing about this idea of what can we do to help prevent NEC. So we know that breastfeeding and using either mother's own milk or donor's milk really is one of the best things that we can do. So our smallest babies obviously are not going to be breastfeeding, but if we think of breast milk as medicine, we're going to be more successful in kind of helping parents understand why either we need to produce, or if we can't, that we can get some donor milk. Again, probiotics has stated, the FDA has said that this is not regulated and should not be used. Most units, I think, have gone away from it. I do think there's probably some out there using it. Do I think there's a future for probiotics? I do. The Incubator podcast, one of my favorite podcasts, has done a lot of podcasts about probiotics. Highly recommend going and listening to that. They really do kind of have a forward thinking of like, what do we think this is going to look like? Are they using probiotics in other countries? How have they been able to regulate it? We talked about the feeding protocols, so standardized slow and gradual advancements of enteral feeds has been the number one prevention technique found in the evidence. So delaying feeds in high-risk infants, for me, the units I've worked on, that is for babies on high levels of pressure, so dopamine, greater than 5 mics typically, where we're not just doing it for like kidney perfusion, but we are doing it because the baby's blood pressure is low. Maybe they don't have urine output. Maybe their cap refill is terrible, addition to what their blood pressure looks like. So we're probably not going to feed it, and we're going to delay on those sickest babies because we don't want to put food in something that's not getting perfused. Kangaroo care, daily, all the time, whenever they can, along with oral immune therapy to increase healthy gut flora, and then preventing unnecessary antibiotic use. One of my favorite questions to ask new nurses is, when do you think we should tell parents about NEC? When do you think is the best time to bring it up? And you will see people kind of pause and think about that because it is big and it's scary. And we don't want to scare our parents, but we also don't want them to be caught off guard. The NEC Society talks about that a lot. Like, I never heard about this. I didn't know this was a possibility. So we really encourage education about NEC to begin when we're doing any of those things that are kind of NEC preventers. So if we're doing oral immune therapy, why are we doing oral immune therapy? Telling our parents, hey, this is one of the things we're doing to build up a healthy gut biome. Okay, are you pumping? Okay, you're not pumping, or could we help you pump? Why? Because we think of breast milk as medicine. It is helping to prevent necrotizing enterocolitis. Okay, you can't produce milk, or you're not going to. Can we use donor milk? This is why we are using donor milk when we're getting our consent. Having those conversations early and often is going to be helpful in them understanding what they can do. Also, then we teach them like, hey, hand hygiene, washing your hands, wiping down your phone, not having like long nails, not coming in when you're sick, all of these things that we can do to help prevent NEC. The gradual introduction of feeding, I think, is another time. Parents often want to know, like, why can't we just feed them? Why do you have to put them on TPN? Why do I have to put this PICC line in? And that's that idea of what our feeding protocols are. Tell them those early signs of NEC. Hey, let us know. Are you noticing your baby has an increase in vomit? If you have a bloody stool, if they're lethargic, all of those things, and have them be an active participant in their baby's care. They are a care team member, the most important one. So teaching them those things, having them alert us when they notice changes is going to be vital. So we know that NEC is the most sudden onset disease that we really, along with sepsis, especially GBS sepsis, that we really just never expect. No matter how cautious we are, there's still babies diagnosed with NEC every year. It's not gone. We're working our best. But if we know our risk factors, we use our preventative measures, our thorough assessment. Assessment is one of the first things I ever talked about on Teach Me Tuesday, so you can go back and find that one. But assessment as a bedside NICU nurse is our toolbox. It is our toolbox of all the things that we can bring out and notice those subtle changes in our babies. It's really important to remember when you're looking at the statistics that babies don't typically get NEC in that first 1 or 2 weeks of life. So when we're feeding those 23, 24, 22 weekers, we're usually very cautious. Often those babies are having spontaneous intestinal perforations, or SIPs, which are very different than a perforation from NEC. NEC is typically in a baby who is a few weeks old, anywhere from 3 to 6 weeks old, so they might be 30 to 33 weeks corrected at this point. If our assessment has been good and thorough this whole time, we will notice those sudden changes, because our hope is to have a future without neck, so we don't have another baby that goes through this. Thank you for joining me today for this Teach Me Tuesday. I hope you enjoyed it. Please comment any questions or feel free to message me.